So, how all the clinical heart failure patients, that is class C, stage C patients are classified. So, once they got admitted with a decompensated or acute heart failure, they can either go to resolution of symptoms. They are still in stage C. Symptoms have resolved. That is, they are no longer dyspneic on exertion. They are able to carry on their own activities without any breathlessness. Or with symptoms, there is resolution of the heart disease also. That is, either the LV function is completely improved to normal, more than 50%, or the LV cavity dilation has reduced and biomarkers have become normal. So, either symptom improvement or symptom with structural improvement. So, this is resolved heart failure. Persistent heart failure, either symptom or the presence of LV cavity dilatation and low ejection fraction persist, or biomarkers persist to be elevated. Worsening heart failure, the trajectory is uphill, that is, there is worsening of the LV cavity dilatation and symptoms or other organ involvement like cardiorenal syndrome. The other one is the first category, that is new onset or de novo heart failure, patient getting evaluated for the first time with breathlessness on exertion. They are newly diagnosed with heart failure based on the clinical examination, biomarker and non-invasive evaluation of filling pressures by echo and no previous history of heart failure. So, this is a trajectory of clinical acute heart failure. The other classification based on the EF. So, reduced EF is EF less than 40%. Normal EF is ejection fraction more than 50%. 40 to 50% is called mildly reduced or mid-range, MREF. This is a very gross classification which does not include RV function. So, this is only one of the parameters. It may not completely encapsulate all the heart failure clinical syndromes. So, heart failure with reduced EF, EF is less than 40%. Improved EF. So, one ejection fraction at one point of time may not give a good clue. So, when we see in 2-3 weeks time, the heart function which has been less than 40%, has improved more than 50%, or at least there is 10% improvement in EF, then it is called heart failure with improved EF. Mid-range or mildly reduced EF is 40 to 50%. So, 50% is normal, but why they are called heart failure with mid-range EF? Because there is evidence of elevated LV filling pressures either at rest or during exercise, or elevation of the biomarkers. So, even if the EF is normal, there is some evidence of heart failure either in the form of non-invasive measurement of filling pressures or biomarkers being elevated. Heart failure preserved EF, most of the time patients admitted for some other reason like COPD, asthma exacerbation, or for pre-operative or post-operative evaluation. There is clinical evidence of heart failure by like anasarca or evidence of pulmonary congestion, and NT-proBNP is positive but their EF is normal. Those are the people who are classified as heart failure with preserved EF. There is evidence of heart failure, but ejection fraction is more than 50%. So, elevated biomarkers, either non-invasive or invasive. So, if there is a central venous line, the central venous pressure is elevated. Or more commonly, echo is suggestive of diastolic dysfunction. So, either spontaneous or provocable, provoked either with exercise or post-operative stress or hypoxia. So, these are the group of people who will come under heart failure preserved EF. So, the diagnosis of heart failure preserved EF, it can be clinically challenging. Most of the patients more than 60 years of age on antihypertensive therapy with some amount of LV hypertrophy, LV wall interventricular septal thickness, or who is having a paroxysmal atrial fibrillation, or echo guided assessment of pulmonary pressure more than 35, and biomarker being elevated when they are hospitalized for some other reason would fall under heart failure preserved EF. So, how do we evaluate this? We have to give a short trial of mineralocorticoid receptor antagonist or a short trial of low dose diuretics and re-evaluate after a period of 2 to 3 weeks. So, this is a very difficult category to diagnose or be sure about our diagnosis, but follow up or multiple evaluations for improvement in symptom as well as the biomarker is required.